140,000 Australians now living with type 1 diabetes in Australia, and approximately 8 people are diagnosed every day with type 1 diabetes. So it's a major health problem for us. And the rates are actually going up rather than going down. So it continues to be one of the major NHMRC health priority areas for treatment. Type 1 diabetes is typically managed with a combination of insulin therapies, often given by pumps or intermittently by injection. This is now used in combination with technologies such as continuous glucose monitoring, which is one of the huge advantages that we've had, or advances that we've had in management of diabetes, because it gives really good indication of when the blood sugar is going too high and when the blood sugar is going too low. And in addition to that, alarms can be set for the person wearing the CGM so that they can be notified when the sugar is too high and too low. And as such, it's been a significant improvement in the way that we've been able to manage and treat type 1 diabetes.
Diabetes for me hasn't always been a part of my life. It was something that came later, at 20 years of age. In fact, in January 2024, I was diagnosed. This was completely unexpected nor predicted, as I had no prior history of diabetes in my family. I grew up playing a magnitude of sports, whether that was team sports, individual sports, you name it, I was doing it all. Thanks to my parents, they drove endless hours around the country, ensuring that I had every opportunity I've ever wanted. And that's something I'm extremely grateful for. So yeah, growing up, I was always extremely active. I was also very fortunate that I was able to travel the world from a young age, watching my dad compete in Ironman triathlon. This exposed me to some of the greatest endurance athletes ever and showed me what it would take to get to the highest levels, which laid the foundations for where I am now, living out my dreams of becoming a professional cyclist. And I think that the lifestyle that I lived prior to diagnosis was one that helped me really transition into diabetes quite easily, because I had healthy habits set up. I knew what the positive benefits of doing exercise were. I knew how that eating well, sleeping well, all those little things meant so much in life, and they go hand in hand with diabetes as well. So it really gave me a leg up and I feel like a fast forward in learning and adapting to type 1 diabetes.
As a pharmacist and credentialed diabetes educator, I get asked a lot from pharmacists and other medical colleagues around the aspects of healthy eating and exercise or activity, especially with type 1, people living with type 1 diabetes. And I guess it's really important to understand that it's healthy eating for everybody. We all should be making healthier choices and keeping active, but it's a bit more prevalent with type 1 diabetes. We have that carbohydrate component. So we're looking at making sure that we're matching our insulin requirements to our carbohydrates. So it's a little bit different in that there is a lot of emphasis placed on carbohydrate counting and knowing what to eat and how activity all interplay with our insulin requirements. And I get asked a lot of questions around that and how to manage it. So as a credentialed diabetes educator, we have the knowledge and skills to be able to guide people in that area, to be able to work with them, because everyone is individual, but to be able to work with them to look at things that may affect their blood glucose levels, such as the different food types that we eat, the activities that we do, how it impacts on the blood glucose level, and ultimately how that then impacts on insulin adjustment. And titrating that insulin to suit those situations is really important in helping to guide that person to be able to be confident enough to do that. And that's part of diabetes management.
What impact do I think exercise has on diabetes? I think exercise and healthy living is the single most important factor in managing type 1 diabetes for me. When I'm exercising, when I'm eating well, when I'm sleeping well and adopting healthy habits constantly, it's when my diabetes management is at its best. For me, the long days on the bike, the good sleep, the good eat means that my time in range is drastically higher than those when I'm in periods of rest. And I really find that managing my diabetes so much easier. For example, in a big training block, when I can set up my routine, when I can set up my rhythm, I find that, it is quite easy to stay in range, but then those periods of rest are really challenging for me, where I'm not so active, where the muscles are not so sensitive, and I really have to make a lot more decisions on what I'm doing, how much insulin I'm taking, and when I'm taking it. I feel that the resources that we have available to us now and the technology, such as continuous glucose monitors, pumps, pens, you name it, whatever you need, you have, is a real game changer. For example, I don't know how you would have done it 10, 15 years ago when you were completely out of the loop and the only way you could physically see your blood glucose was take a finger stick. For me, it's now only always one tap away. So whether I'm on the bike, whether I'm at home, whether I'm in bed, it's so easy to quickly take a glance and make a decision based off whatever my glucose is. This has really allowed me to enable strong control over diabetes and ensure that I'm never too far out of range for an extended period.
Upskilling in diabetes education as a clinician and as a health professional when you're looking after people who have diabetes is really, really important. To be able to guide them and give the evidence-based information, especially around things like low blood glucose levels, so hypoglycemias, knowing how to help someone manage that, and especially if you're looking after someone that may be experiencing a low blood sugar, it's really important to have the knowledge and education on what to do and how to help that person. And I think it's really important that healthcare professionals understand that. They understand how different activities can impact on someone's blood glucose level, such as the types of foods that they've eaten, have they not eaten. You know, it's quite often everyone's very busy and they're rushing to an appointment. Has your patient eaten? Are they experiencing a low blood glucose level? What activities? How does activity affect it? So having that knowledge around how that all impacts on blood glucose levels and also insulin requirements is essential as a healthcare professional. It's very important to be able to have those knowledge and skills in order to be able to look after the client or your patient. It's really important for clinicians to understand diabetes stigma and diabetes distress, especially in people living with type 1 diabetes, where it's a constant monitoring, it's a constant looking at what your blood glucose levels are. Do I need to adjust insulin? Do I need to eat more to prevent a low? It's all about preventing those complications. And the technology that we have with CGM, with insulin pumps, it allows the person to be able to manage the condition. We can manage it, and we can be able to do everything that we want. We can perform the activities that we want. If we want to be able to go and play soccer or football, or we can do that. And that technology allows it. It's equally important too to understand that the other stresses that can occur, like diabetes distress, being able to recognize those red flags. So when somebody is struggling in their management, they've got these management tools and we know how to use them, and it's about steering them and guiding them to be able to go back and use those tools and be able to manage it so that they can continue living a healthy and happy life. And that's ultimately what we want to do as clinicians. So having that knowledge and skills to be able to recognize those red flags, to be able to guide them in their management tools, so being able to assist them when they're looking at these adjustments, having sick care day plans in place, all of those things to help people manage the condition, and it is quite achievable to do.
I think I want to ride the biggest bike races in the world. Like every young kid, I grew up dreaming of the biggest stages, wondering what it would be like and how I could get there. And now I'm in an extremely fortunate position here at Team Novo Nordisk, where I'm living out one of my dreams of becoming a professional cyclist, which is something that I'm extremely proud of, yet so inspired to keep pushing for more. I think that to stand on the start line in the biggest races of the world is what wakes you up every day. And for us, there's no bigger than the Tour de France.
There's really two ways that you can treat diabetes with a transplant. One of which is with a whole pancreas transplant that is frequently combined with a kidney transplant. Now, the problem with this is that in the last 30 years, there have only been 690 Australians have been able to access that treatment. So a much more interesting and potentially acceptable form of treatment is to transplant the cells that are required that produce the insulin therapy. And this is called an islet cell transplant. This is typically comes from a deceased organ donor from which we have isolated the islets and then given the islets intraportally, by which I mean cannulation of the portal vein and then direct embolization of the islets into the liver parenchyma. Now, this has been the gold standard for islet cell transplantation really since 1990, when it was first performed in Minnesota. But the problem that we've got with that is that the islets, when they're transplanted into the liver, are not retrievable and they're not biopsiable. And in addition to that, about 75% of them will die within the first 24 hours. In other words, it's really not an optimal transplant site. So around the world, we've been looking for different sites or different places that islets can be transplanted, with the idea of being able to potentially diminish the amount of cell death that happens during the transplant procedure, potentially also have them in a position where we can biopsy them and monitor them, and therefore pick up rejection early, which is one of the problems that you have when you've got a cell that's been transplanted deep into the liver. The results of the Inceptor study were presented at the European Society for Endocrinology meeting in Copenhagen. This was a meeting of over 9,000 delegates, and it was presented as an oral abstract. It was subsequently presented at the International Pancreas and Islet Transplantation Association meeting, which was held in Pisa in Italy. Both of these meetings were to key opinion leaders within the field and resulted in a significant degree of excitement in the field, because the major outcome of this study was that we were able to demonstrate survival of pancreatic islets in one patient out to 3.5 years after implantation. This is quite exceptional because our sites outside of the liver have not been associated with long-term islet graft survival. So we were extremely pleased with this result. In addition, all 3 subjects who went into the trial had a reduction in their insulin requirement, up to 62% being reduced during the period of the study, and a reduction in their hemoglobin A1C down by greater than at least 1 percentage point. These are quite remarkable outcomes. The first participant in the study has still ongoing function even as we speak.